everyone. My name is Eshaan Satyawada, and today I will be taking the time to discuss my research on how machine learning can be utilized for public cardiovascular health analysis. Before I get started, I would just like to introduce myself. I'm a rising senior at Northwestern High School, located in the Metro Cleveland area of Ohio in the United States. Some of the activities that I am engaged with at school include Science Olympiad, Band, Key Club, Link Orientation Crew, National Honor Society, National French Honor Society, and French Club. I'm also a biomedical research intern at Case Western Reserve University and university hospitals, where I'm currently working on projects studying the biological mechanisms behind atherosclerosis progression, as well as public cardiovascular health data science and machine learning, which I will discuss further in my presentation. I'm also the co-founder of the My Matters app and an active volunteer in my community. So you may be asking yourselves, why is cardiovascular disease a global health issue? Well, cardiovascular disease is in fact the leading cause of mortality worldwide, accounting for approximately 19.41 million deaths in 2021. This makes it the cause of almost 1 in 3 deaths worldwide. Cardiovascular disease is a disease that isn't specific to a certain population or area. It affects a diverse range of people across the globe. And as our world rapidly urbanizes and develops, the link between cardiovascular disease and urbanization has become increasingly apparent. So it's imperative that we address this issue soon. To further demonstrate the global scale of this issue, this graphic of shares of annual deaths due to cardiovascular disease in 2021 shows how cardiovascular disease isn't just an issue isolated to specific countries or regions of the world. It's truly a global issue affecting all nations. Common cardiovascular diseases include heart attack, stroke, heart failure, arrhythmia, and heart valve complications. Causes of these diseases include unhealthy diet, physical inactivity, air pollution, tobacco use, and alcohol misuse. It's important to note that while habits contributing to cardiovascular diseases are well known, the onset of the disease itself can also influence engaging in these harmful behaviors. Many public health interventions in recent years have begun to focus on prevention and management strategies to improve outcomes for individuals and communities affected by cardiovascular diseases. However, these strategies and interventions largely remain limited to larger cities and more affluent nations, and more effort needs to be made to bring such research and awareness to developing nations and smaller cities around the world to achieve global health equity. My research with university hospitals specifically aims to identify cardiovascular disease, analyze their causes and correlation to other factors, and derive innovative treatments in underserved populations in Cleveland, Ohio. While the issue of cardiovascular disease is widespread, it can affect different populations in vastly different ways. Cardiovascular disease disproportionately affects urban and rural communities, females, developing nations, economically disadvantaged individuals, and individuals of African, South and Central American, and Asian descent. The graphic on the right highlights how economic status plays a role in the presence of cardiovascular disease risk factors. As you can see, individuals of low affluence have a higher percentage of their population affected by cardiovascular disease risk factors compared to medium affluent and highly affluent populations. Understanding these disparities quickly and accurately is crucial for addressing the growing cardiovascular disease problem effectively. This is where machine learning comes into play. So machine learning is essentially a branch of artificial intelligence focused on building systems that can learn from and make decisions and predictions based on data. Developing a machine learning model involves collecting data, pre-processing, selecting a specific model, training, validating, evaluating, and developing a final comprehensive model. Examples of different model approaches include supervised learning, unsupervised learning, and reinforcement learning models, but there are several others that can be used as well. So specifically, how can machine learning help combat the global cardiovascular disease issue? Well, machine learning can improve diagnostic accuracy and can utilize a large amount of data to generalize to a public health scale. It can also handle complex data and analyze multifactorial data through meta-analysis, and multifactorial data and complex data are common of cardiovascular disease datasets. Finally, machine learning can also be used for early detection and prevention by generating predictive analytics of cardiovascular diseases. By leveraging these capabilities, machine learning not only broadens our general understanding of cardiovascular disease, but also opens new avenues for innovative research, such as my project that I'm working on as part of the team at university hospitals. I'm working as part of the Clarify project, an initiative by university hospitals involving 30,000 patients who underwent low or no charge coronary artery calcium screening across Northeast Ohio. Our project aims to link socioeconomic and environmental variables with clinical measurements like coronary artery calcium scores to predict cardiovascular diseases using various machine learning approaches. By using unsupervised machine learning clustering methods, we analyze socioeconomic and environmental variables to create patient clusters based on cardiovascular health outcomes to help us gain a comprehensive understanding of who cardiovascular disease is affecting most. The goal is to develop a robust model capable of discerning significant differences and associations between clinical measurements and cardiovascular health outcomes, enhancing our ability to personalize prevention and treatment strategies effectively to underserved populations in Cleveland, Ohio. So, regarding our findings, it's important to note that specific details cannot be disclosed as of now due to health privacy protection laws surrounding patients in the Clarify project, and as the project is not fully complete yet. But generally speaking, our model has successfully identified various correlations, both positive and negative, among socioeconomic variables, different clinical measurements, and cardiovascular health outcomes. These insights are represented through clusters that reveal the multifactorial relationships at play. As we move forward, there are several avenues for improvement. First, we aim to integrate additional socioeconomic and environmental variables to further enrich our model's insights. Enhancing accuracy and applicability will involve working with a larger and more diverse data sets. Looking ahead, our findings could potentially be generalized to larger populations, whether it be statewide, nationwide, or even internationally. Furthermore, exploring the application of deep learning and convolutional neural networks could allow us to more rapidly and accurately assess coronary artery calcium scores, which are crucial for our project. Despite all the benefits that machine learning has, it's important to note that it has significant limitations as well. So I pulled a quote from one of my favorite novels, When Breath Becomes Air by Paul Kalanithi, and it reads, "When there's no place for the scalpel, words are the surgeon's only tool." So applying this to machine learning and artificial intelligence in general, while machine learning and AI are great tools to have, they cannot replace the human aspects of healthcare, such as compassion and human judgment of morals. Machine learning and AI can also make incorrect generalizations, potentially providing correlations or analyses that are not statistically significant, or those that are nonsensical or inaccurate. Therefore, findings generated by machine learning and artificial intelligence need to be verified by humans for accuracy and contextual understanding, which is another huge limitation to consider. As I bring my presentation to a close, I would like to thank the principal investigators and mentors in my lab that have helped me tremendously with my research projects. I'd also like to give a special thank you to Case Western Reserve University, University Hospitals, Johns Hopkins University, and the Global Health Leadership Conference Committee for giving me this opportunity to speak to all of you. Here are my references, and last but not least, I would like to thank all of you who have listened to my presentation so far. I truly appreciate it and hope you were able to learn something new. If you have any questions or comments, please feel free to reach out using the contact information provided. Thank you once again and have a wonderful day.